to South First. I am Chetana Belgere, and today we are in conversation with Dr. AS Soin, India's top liver transplant surgeon with over 4,100 surgeries under his belt. We welcome you, sir. Sir,
okay.
As a liver transplant specialist, could you provide an overview of the most common liver diseases you encounter in your practice these days?
So among adults, there are 4 reasons why liver failure can happen. One of the main reasons is non-alcoholic fatty liver disease, which happens to people who have uncontrolled diabetes, who have obesity, who have bad lipids like dyslipidemia or bad cholesterol, and generally who have a sedentary habit and who have been consuming junk food for many, many years, fried stuff, processed stuff, sweet foods. So people who indulge in this kind of lifestyle and or who have obesity, dyslipidemia, and uncontrolled diabetes, and occasionally genetic predisposition, they will get non-alcoholic fatty liver disease. Now, India has about a 35% incidence of non-alcoholic fatty liver disease among adults, which means out of 10 people walking on the road, 3 to 4 people will actually have a fatty liver because of a non-alcoholic reason. And about 20% of these people will eventually develop significant liver disease, and 5% of them may actually develop a liver cancer. So that's a very high incidence.
Okay.
So that's the recent scourge that's causing, liver disease, liver failure, liver cancer.
Okay. Okay.
The second reason is alcoholic liver disease, which is excessive consumption of alcohol, typically more than 10 units a week for over 7 to 8 years. That's the bottom end, as in that's the level at which significant liver disease or cirrhosis can happen to people. Of course, everyone that consumes that much doesn't actually get cirrhosis, but people can start having cirrhosis at that sort of level of consumption of alcohol. So that's the second reason. And the third reason is hepatitis C, and the fourth is hepatitis B. Both of the latter two are viral infections, and they are transmitted in quite the same way as AIDS, which means by getting infected blood from a person through syringes, needles, dialysis machines, blood transfusions, through sexual contact, through body fluids. AIDS, hepatitis B, and hep C are all spread the same way. Now, hepatitis B has a vaccination, so everyone must get hepatitis B vaccination as a prevention. And hepatitis C does not have any vaccination, but it has effective medicines. So if somebody is detected to have hepatitis C early on or early enough, they can actually have hepatitis C treatment with medicines, which are 99% effective in curing it in the early stages. But once the damage progresses to liver damage that results in scarring and cirrhosis, then at that stage, liver disease is not reversible, whatever be the cause.
Okay.
So these are the 4 reasons: non-alcoholic fatty liver disease, alcoholic fatty liver disease, hepatitis C, and hepatitis B among adults.
So there is a general belief that, only those people who drink alcohol end up with liver diseases. But then, I'm just asking a very basic question. How do we know that there is something wrong with the liver, like with my liver? Or, how do we actually recognize that at early stages if we're talking?
Okay, fair. Sure. So anybody who's been having excessive alcohol, or who is obese, or who has diabetes, or who's got unhealthy diet and sedentary habit, and who has a family history of diabetes and obesity, so these are high risk groups.
Okay.
So they should do regular tests.
Okay.
And also people may know that they have hepatitis B or C. So any known disease in the known liver disease of these 4 reasons within the family or within the person, then they are a high-risk candidate for developing liver disease. Okay. So they should be doing regular liver tests, which are called liver function tests. It's a blood test. And ultrasound of the abdomen, specifically the liver, and something called fibroscan.
Okay.
So these are the 3 tests which will tell anybody if they have liver disease, because liver disease, features will show up in any or all of these tests.
So you had recently done a triple swap liver transplant, and that was probably the first of its kind in the country. So, what are some of the advancements and breakthroughs that have been happening in liver transplantation techniques that have come up? Like I've heard about, the use of machines to store livers for 1 or 2 days. So there are a lot of new things which have come up. So anything which you could talk about?
Yeah, sure. I'll talk about all of these things. I'll touch upon all of these things. Obviously, can't talk in detail.
Yeah.
So you must understand that advancement in the treatment of liver diseases and liver transplantation specifically have to do with two basic things. One is to increase the access and availability of liver transplantation to more and more patients of liver failure and liver cancer so that more people are saved. And the second is to make it more successful and safer for the patients and safer for the donor. So all the innovation and new technique that get developed have to do with these two areas: safety and success, and access. Right? So now let's analyze each one of them. So there are situations when, so first of all, cadaver donation, which means donation of organs by a brain dead person in an ICU situation, can save many lives. One person donating in such a way, that means the family of such a deceased person donating can save many lives, and that should be encouraged. Unfortunately, there's not enough of it happening in the country. Currently, only about 15% of the transplants are done through the cadaveric organ source. 85% of the transplants are done by living donor liver transplantation, right? So on the cadaveric side, to increase the usability and success rate of liver transplantation, now machines are used. And two common machines that are used are normothermic machine perfusion, NMP, and HOPE, which is hypothermic machine perfusion, okay? And there is a third technique called NRP, normothermic regional perfusion. So these three techniques are basically used to make livers of these brain dead people healthier prior to transplantation. So some of them have fat, some of them have been damaged because of lack of blood supply. After all, these are livers taken from people who have died. So obviously they've had infection, they've been in ICU, they've had low BP, they've had a variety of problems. That's why they died. So the quality of these organs may not be perfect, and the duration for which these organs can be kept outside of the body is enhanced by these machines. And also some of the damage and fat present in these organs is cured prior to transplantation. So that's the use of these machines. And this is all in the last 7-8 years. So this is new. Now let's move to living donor liver transplantation. Now, the one of the key advances in donation or donor surgery is robotic liver surgery. So robotic liver surgery is a system where I and my team are one of the very few teams in the world that offer this. And so what we do is basically robotic surgery is keyhole surgery, where we make 3 or 4 small little holes in the tummy through which we put in fine instruments which are controlled by the surgeon through a computer console. So robotic surgery is not done by the robot. Robotic surgery is done by a human surgeon, but the human surgeon controls the computer. All robots at the end of the day are computers, right? So we control the computer that has the instruments that do the surgery. So we control the instrument. So anyway, the surgery is done, and when the part of the liver that needs to come out, which is the right side of the liver, usually from an adult to an adult. So when the right side of the liver is ready to come out, we remove this through a small cut, about 9 centimeter, 10 centimeter cut, just above the pubic bone, below the belt. So the advantage of that is that open surgery, which normally has a cut like this, there is no big cut on the front of the tummy in robotic surgery. There's a small cut, with much smaller cut at the bottom, where it's not seen. And because the cut is smaller, the pain is less, the recovery is faster. There's no muscle cutting in the robotic incision. So for young people, the recovery of abdominal strength is much better. And so donors have taken to it very well, and it's much easier to motivate young donors and families now that we have robotic liver surgery. So that's one. Then there may be situations in which families have a patient whose blood group is B and they have a medically fit donor whose blood group is A. Now, typically for living donor liver transplantation, we need donors who are 18 to 55 years old, who are family members, who are not overweight by more than 10%, and who have compatible groups with the recipient, which means if the recipient is B, if the recipient is B, then they should be B or O, and so on. But sometimes they have incompatible blood groups. So we have developed two innovations over the last 10, 15 years to overcome that problem. So one is called swap liver transplantation, which you just alluded to a little while ago. And the other is called ABO mismatched or ABO incompatible transplantation. So both are possible now. So swap transplantation is a concept where the family A has blood group B recipient and an A donor, and the second family has the opposite problem. That means A recipient and B donor. Then the two donors' livers will be given to the other family. That means the livers will be swapped. So all four operations, the two donor operations and the two recipient operations, all happen at the same time, same day. We have large enough teams to conduct that. So livers are exchanged typically between the recipients and the families, and each recipient gets their blood group matched liver, so both the recipients can be saved. If the swap is not done, then either they have to undergo a slightly higher risk incompatible transplant or not have a transplant at all. So this is an advance that has helped hundreds and hundreds of families in our system. And triple swap, so this is a double swap, as in two families swapping livers. So triple swap is an extension of this concept to three families. We can extend it to 4 or 5 families also. So the other is ABO incompatible transplant. Now, what happens is that typically blood group compatibility is important in transplantation, but now we have developed techniques which we specifically call immunomodulation, in which if I, as a donor with B group, have to donate to my brother who's group O, then I'm not strictly compatible. But I can still donate if my brother, the patient, is prepared for 3-4 weeks by immunomodulation. We give special medicines to for the body not to produce the anti-B antibodies. And we also wash out the pre-existing anti-B antibodies by doing plasma exchange. So this is called immunomodulation. So by immunomodulation, a B group guy can donate to an O group person. And that's what's called ABO incompatible transplantation. We were, again, the first ones in this part of the world to do this. We've always been publishing everything that I've told you about. We like to publish in the scientific journals. So this is ABO incompatible transplantation. And there is another concept called dual lobe transplantation, which means if there is a big recipient, 100 kilos, and a 50-kilo donor, let's say typically a father who's 100 kilos and a daughter who's 50 kilos, her right side of the liver may not be enough for the recipient. So we can actually get 2 such donors to donate half a liver each. And both these lobes can actually go into the same patient. So that's called dual lobe transplantation. So that's as you can see, all this increases the access to transplantation for patients. That means more and more patients can be transplanted. Otherwise, people with incompatible blood groups, people who are too big for their donor, they will not have a transplant.
Yes.
Right?
Yes. So what are
these are some of the advances.
Okay, so when you're looking at, I mean, this is really new to me, some of these, at least I've read about it, but when you look at the survival chances of such, how has it been, sir? I mean, after the, you've done
So, when I did the first liver transplant in India on the 5th of November, 1998, and then 10 days later, I did the second successful transplant in India on 15th of November, 1998. It's been a long journey. We've done about 4,100 liver transplants, which is the highest number in this country and possibly the second highest in the whole world in living donor liver transplantation. So we progressed from our initial success rates in the first 20 cases 25 years ago were like 65-70%, but now we are at about 97%. In the last 400 odd cases, we have 97% success rate among adults and about 98% in children. So that's the success rate. That means out of 100, 98 or 97 will walk out. Donors, touch wood, they all remain well. We always say donor safety is like 99.9%. That 0.1% risk will be there in any surgery, even when you're walking on the road or driving a car, like in everyday life situation. So that kind of, apart from that kind of very, very minuscule risk, donors really have no risk. And they are restored to normal life quality and expectancy after donation. I mean, the living donors. And patients also get an excellent quality of life, as you know from your friends' experience. They also get an excellent quality of life after transplantation.
Yes, yes. So,
and normal expectancy of life. Yeah.